Hello, my name is Sam Farrer. I'm a vascular surgeon from Melbourne Vascular Associates, and this is a short video on ovarian vein embolisation, and this is a guide aimed at patients. Of course, the usual disclaimers, this short video is general in nature, and you should of course discuss your individual circumstances and condition with your doctors involved in your care. So ovarian vein issues are a part of a group of disorders called pelvic venous disorders. When we have vein issues in the body, they're usually due to what we call venous reflux. So if you look at the image on the right, the job of veins is to help return blood to the heart against gravity, and it does this with the aid of valves. And the job of valves is to allow the normal forward and upward flow of blood back to the heart. When we have pelvic venous disorders, due to reflux in the ovarian vein, this causes pelvic venous congestion. It is actually one of the common causes of pelvic pain in women, particularly those who've had pregnancies in the past. And what happens is these veins, particularly on the left side coming from the left ovarian vein, cause engorgement in the pelvic venous plexuses in the pelvis. So what we have here, we have the left renal vein, and then from that comes the left ovarian vein, which then fills the pelvis with additional blood and causes discomfort in the pelvis. We do have a right ovarian vein, but we rarely see any reflux on this side. It usually takes a much more straightforward course directly onto the inferior vena cava. Some common symptoms that people experience are chronic dull aching, particularly pelvic pain, that's often worse after standing for long periods of time. This usually, of course, gets worse towards the end of the day, and particularly during menstruation. It can cause heaviness or a dragging type feeling, and sometimes people can have varicose veins around the groin area or down the thighs, and in some instances can also have lower limb varicose veins that are being fed higher up from the ovarian vein itself. So how do we work it out? We often just start with an ultrasound. If we can see the ovarian vein pretty easily, we often use that as a surrogate marker to say, yes, ovarian vein reflux is present. Normally, the ovarian vein shouldn't be easily findable on ultrasound, so the mere fact that we can see it at all is a good sign that there's likely some evidence of ovarian vein reflux. We then sometimes use CT to look for an enlarged ovarian vein, and in some instances we would consider doing an MRI. But the gold standard is just to put a tube into the vein and have a look and see what's going on if we really think it is present. Once we've confirmed the diagnosis through those tests and a thorough history and examination, we will then discuss with you whether or not ovarian vein embolisation should be performed. If a decision to proceed with embolisation is reached, then the procedure is a fairly minimally invasive procedure. It involves coming into hospital. A thin tube is put into the groin through a small little nick in the skin, and the tube is advanced into the ovarian vein, and metallic coils are then placed into the vein to seal it shut. This is what it looks like. In this case, I've accessed the groin on the right side through the femoral vein. I've gone up and around into the renal vein, and I've catheterized the renal vein directly. And here we can see a very large ovarian vein feeling downwards towards the patient's pelvis. This ovarian vein was on the larger end of the spectrum, but we often see this sort of dilated, large ovarian vein in these sort of cases. Once we're happy, we get all the way down into the pelvis and we start advancing metallic coils. And by this way, we then essentially block the ovarian vein so we can stop blood using this pathway to stagnate and stay in the pelvis and cause discomfort. It's usually done as a day case, and most patients will then go home more or less straight afterwards. For a case like this, where the ovarian vein was quite large, it's used probably close to 8 to 10 coils. If the ovarian vein is refluxing or problematic, but it's smaller, we can sometimes get even away with 3 sets of coils. So how the procedure looks, you arrive on the day, you're admitted to the hospital, the anaesthetist will put a small drip in the arm, You may have some local anaesthetic and sedation or go to sleep if you really so desire. As you've seen in the picture, the catheter is put into the vein via the right groin. We get up and around, and then we put the coils in, and then we make sure we're pretty happy before finishing, and we usually rest for a couple of hours before going home on the same day. Afterwards, there may be some mild discomfort at the puncture site, which is usually well managed with some Panadol or anti-inflammatories. For the first week, we sort of suggest just to avoid really heavy lifting or strenuous exercise. You can get some mild pelvic or back pain as the area responds. In really severe cases, I've seen even episodes of constipation, and I think this is just from a lot of inflammation and irritation in the area. But within 2 to 4 weeks, most people are back to normal. And as we get closer to 3 months, we then see, as the veins start to shrink, that the symptoms continue to improve. In the most extreme cases, I've seen up to 6 months for improvement to be seen, but it's certainly not a quick process. But the good news is generally a fairly successful procedure, with large studies suggesting that most people have fairly good results at 12 months. What are the benefits? Well, there's no open surgery. It's only a tiny nick in the skin. It's a day case under minimal sedation with minimal to no blood loss. And people are pretty much back on their feet and home straight away with, as you've seen, a high rate of success with good long-term outcomes. Some of the risks involved are bruising or discomfort at the puncture site. There can be, as I mentioned in the previous slide, a temporary increase in pelvic pain due to inflammation in the area. Very rarely we can get infection or allergy to the materials that we use during the procedure, and there are case reports, but fortunately none within our practice, of the embolic material embolizing to other parts of the body, and in some cases symptoms can recur in the future which may prompt a re-evaluation. So if you'd like to discuss this, please get in touch with the clinic. You'd need a Medicare, a GP referral to see us, and then when you do see us in the clinic, we will perform an ultrasound on the same day to see if there is any evidence of ovarian vein insufficiency or reflux, and if there's any concerns or questions, we may recommend either a catheter test to see if there's any ovarian vein reflux present, or a CT scan or an MRI in some selected cases as well.